Thank you for providing me the opportunity to present on a recent systematic review that I've had recently accepted for publication as part of my PhD. Have you noticed that people with knee osteoarthritis move differently when they're walking, standing from a chair, or using stairs? What you are observing is that people with knee osteoarthritis have altered knee joint loading, altered kinematics, and muscle activity parameters. Some examples include increased medial joint loading or knee adduction moment, changes in kinematics such as reduced knee flexion, as well as muscle bracing strategies. Rehab professionals prescribe exercise to help their patients overcome functional limitations and pain associated with the condition. Some clinicians and researchers believe that changing the way someone moves during a functional activity directly impacts on clinical outcomes such as activity limitation or pain. So many physiotherapists and exercise professionals aim to teach exercise in the manner that promotes normal alignment during exercise. So what we wanted to know was, if a person with knee osteoarthritis participates in an exercise intervention, is there a relationship between a change in the way someone moves and their clinical outcomes? So 2 reviews have investigated this relationship in people with knee OA after exercise. And these reviews are limited in that they only investigate gait, but not other activities like sit to stand or using stairs. They included only one movement parameter, knee adduction moment, and not other parameters. They reviewed only RCTs, but not other study designs. While RCTs are good to tell us if a treatment works, this study design is not essential to establish relationships between outcomes. Finally, they reported between group mean differences, which provides information about the effectiveness of an intervention, but not about relationships within a group or an individual. To establish if there is a relationship between 2 variables, correlation analyses can be used. Correlations are calculated from individual participant change scores of each variable and how closely 2 variables, such as a change in movement and clinical outcome, are related to each other. Another way of looking at a relationship is if the group of participants changed in both movement and clinical outcomes by comparing average change in each variable within the group. In this review, if both movement parameters and clinical outcomes change significantly at a group level, we call this a group co-occurrence of change. Keep in mind, however, group data can't tell you if people who change in movement are the same people who change in clinical outcome. So we conducted a systematic review asking, do changes in movement parameters relate to changes in activity limitation or pain after an exercise intervention in people with knee OA? RCTs and cohort studies of exercise interventions for people with knee OA were included, and exercise therapy was defined according to the MESH definition. Studies were required to measure at least one knee joint movement parameter and activity limitation or pain, both before and after an intervention. We found just over 3,000 references, of which 22 were included in the final review. Quality assessment was conducted with 2 tools, identifying overall low quality across studies and a higher risk of bias within studies. Due to the heterogeneity across studies, we conducted a descriptive synthesis of the results. Gait was the only functional activity assessed. There were no studies on other functional activities like standing from a chair or using a staircase. I will therefore only discuss the results for gait. There were many gait-related movement parameters you can see here. There were 8 knee joint moment and 15 kinematic movement parameters that were investigated, but there were no studies reporting on group-level data for any muscle activity parameter. Moments were investigated a total of 56 times and kinematics 28 times across studies. And you can see here that the knee adduction moment was the most popular movement parameter investigated, approximating the total number of times that all kinematic variables were investigated. So we then summarized how often a movement parameter changed. Overall, movement parameters changed only 26% of the time they were investigated. It was rare for a movement parameter to change after an exercise intervention, with a change in many knee joint movement parameters or kinematic parameters only changing a fraction of the time. 6 correlations were tested across 2 studies. between movement parameters and activity limitation, 2 studies between movement parameters and activity limitation, and 4 between movement parameters and pain. Change in movement parameters were not correlated with activity limitation, and only 1 of the 4 parameters were correlated with pain, with a moderate correlation between a change in muscle co-contraction and pain. So only 1/6 of the time, or 17% of the time, was there a correlation between a change in movement and a change in clinical outcome. We then looked across studies if a group of participants changed in both gait parameters and clinical outcomes. We found that a change in gait parameter occurred together with a change in clinical outcome only 24% of the time. So this means the majority of the time, in fact, 3/4 of the time, there was no relationship. Also interesting was that when a movement parameter was investigated multiple times, it both increased and decreased. So there was no consistent direction to the change of movement, despite the change in clinical outcome being consistent. Therefore, our review does not support the belief that exists amongst clinicians and researchers that a change in movement parameter is related to a change in clinical outcome for people who have knee osteoarthritis. We draw this conclusion because only 17% of the time there was a relationship in studies that used correlation analysis, and only 24% of the time was there a co-occurrence in the studies that used a group level relationship. We provide the first review that comprehensively reported on multiple study designs and included knee joint movement parameters, summarizing studies that directly investigated a relationship with correlation analysis. However, the studies were of low quality, and we had to calculate the mean change in standard deviation in some studies, which may introduce some error. However, this was calculated in accordance with the Cochrane collaboration recommendations. Also, we're unable to draw conclusions about activities other than gait, as they have not yet been investigated. So why wasn't there a relationship? We know that exercise improves activity limitation or pain, but it may not be because it alters the way a person moves. It may work via a different mechanism. Or perhaps it's a matter of targeting everything better. For example, maybe some people may not be able to change their movement. This might be the case for someone who has no altered movement at their first assessment, or someone who has a fixed deformity. Did the intervention directly address the functional limitation? Squats, for instance, may theoretically change the way a person performs sit to stand, but may have a limited effect on movement patterns such as walking or going up and down stairs. Finally, clinical outcomes in this review were broad and generic. Perhaps questionnaires needed a need to be more specific to the activity. The ideal study design to investigate this would first select a group of participants who have the same functional limitations, who display the same alterations in movement parameters during that activity. Second, use clinical outcome measures of pain and activity limitation that are specific to that particular activity, rather than outcome measures that cover a variety of activities. Third, select an exercise intervention that represents the functional activity the participant has trouble with. And fourth, conducts a correlation analysis to explore the relationship. So what should you do with your patients? Well, first, definitely continue to prescribe exercise. There are so many types of exercise that all seem to work well in the research for activity limitation or pain. We're only beginning to scratch the surface as to which type of exercise is most suited to a patient presentation. If one method doesn't work, you can always try another. But keep in mind, there is insufficient evidence to establish a relationship between changes in movement parameters and changes in clinical outcomes after an exercise intervention in people with knee OA. Clinicians should continue to prescribe exercise while understanding that it's not yet clear what role changing movement has in clinical practice. Stay tuned for the published systematic review, which has recently been accepted for publication, and I look forward to answering any questions in question time. Thank you.